My pleasure to introduce Dr. Vijay Richards. Could you please come up, Vijay? Yes. He's Hospital Infection Control Consultant and Chairperson of the Hospital Infection Control Committee for the Narayana Hridayalaya Hospitals in Bangalore. Areas of interest are hospital infection control, clinical microbiology, antibiotic stewardship. He's a graduate from here, so welcome back. And
the topic given to me was challenges in implementing antibiotic stewardship. I have taken the liberty of adding the last one. How do we overcome the challenges? Because I think that's also very important. I have struggled through the last 21 years to do a few things. Thankfully, my last job for the last 5 years has been a cakewalk in this field. So straight away, we want to take our world back from the bugs. So there are multiple guidelines, processes, you name it, you have everything. Nationally, internationally, an excellent document from India. And essentially, infection control involves quite a lot of things. It involves antibiotic stewardship, involves infection control, research to find new antimicrobial agents, research to find new techniques to test for antimicrobial resistance. However, for this talk, I'm going to stick on to a very basic, the core essence of antibiotic prescribing and making it work. So essentially, how do we use the right antibiotic at the right dose, at the right time, the right route, the right duration, not to forget the right patient. So very simple to look at, but difficult to perform. Anyone in the field of antibiotic stewardship will agree with me. So I've got 3 things which I call universal challenges. So I find these challenging, not only for antimicrobial stewardship, it'll be the challenges that you'll face in any process change or anywhere where you want to make a process change or implement something new. The first challenge is yourself or myself. Can I do it? Well, the answers from WHO and CDC, I've verbatim copied it. Antibiotic stewardship can be implemented effectively in a wide variety of hospitals, and it succeeds if you have a defined leadership, so one person doing it who knows what they're doing, with a coordinated multidisciplinary approach. I really like to highlight multidisciplinary there because that's the key thing. Second challenge, you may feel that you're alone. I may feel I'm alone trying to do this. However, beyond the wall, when I break it out, I can see colleagues who are in with me and who are, we share the same passion, and it is doable by that. So that's universal challenge number 2, overcome. Universal challenge number 3, decreasing resources. So this is a problem everywhere in all fields, not only medicine, in every industry. So how do we overcome decreasing resources? Obviously, we don't have a pot of money where we can just give it to everyone, or I don't have anyone giving me a pot of money as and when I feel like. So I have to make do and use other healthcare providers. So if I've got 1 or 2 doctors in the team, I have to look at outside the box, training nursing staff, pharmacists for antibiotic stewardship. I know many hospitals in India are doing it. We also have resident doctors, your junior doctors, they're a valuable resource. Then being in India, where IT is very important, we've got multiple apps which can actually be our friend. I'll just show you a couple of them throughout my talk. Now coming to the core concepts of antibiotic stewardship and how do we do it in any hospital, the first step is to have an antibiogram. Then based on the antibiogram and the clinical, my clinical colleagues and the processes or procedures done in the hospital, you do the antibiotic policy. The next one is disseminating and implementing it, performing audits, feedback of audits, re-audits, that just keeps going on in a loop, improving as well, and then you're back to your antibiogram and so on and so forth. So challenges in every stage. Antibiogram. You need to have the hospital data on antibiotic sensitivities. Most hospitals don't have a digitized system, so it's a pain to sit and get everything, manually write it or manually enter it in the system. It takes time, prone for transcription error. All of us make mistakes, so that's another thing which will happen. A customized software, which is there in the West for antibiotic stewardship or finding antibiograms, are very expensive. Again, the antibiogram of one area, a surgical area, may be different from a medical area. So to customize it, it takes time, it's error prone. Disseminating it dissemination of the information to different units, again, is time consuming and is a pain at times. I would recommend for those who have not got a software, who are not using WHONet yet, please use it. It is freely available on the net. It's from the WHO. It is beautiful. In fact, it's a very robust software, and there are YouTube videos as to how to use it. I have learned through YouTube how to use it, and it's taken off half my burden, I would say. Okay. Presentation of antibiograms to the clinicians are very vital. It helps them recognize the world that we live in. Not only that, it also helps them to recognize the microbes in their own space. So this is crucial. The more frequent you show it to the clinicians, the better would be the outcome. Now the policy, challenges in the policy. I had to go back in time because few illustrations I quoted have been in the past experience in India and also abroad. People think it's someone else's policy. Why should I follow it? My private patients are different. Your policy is too complex for me. I can't access it when I need to, and so on and so forth. Now, all those are very, very important because those are the barriers that one would have to overcome. And the more you hear about these barriers, you know what to sort out one by one. So taking time to recognize it and sort it out one by one is very important. So possible solutions that I've found: a good clinical rapport with colleagues. It could be clinicians, it could be nursing staff, anyone you work with. Good rapport and a good working relationship, I feel, is the bottom line. That's the foundation for a good antibiotic stewardship program. Without that, nothing will work. Involvement of relevant specialties at every stage, not only at the final stage of implementation. I can't do a policy and say, look here guys, this is the policy. Just have a look, see if you like it. Now, I should involve them right at the beginning. Short meetings specific for a goal at different times and venues convenient for the clinical staff, because I don't want to pull them out of their critical care unit or out of the department for something which may not be a top priority for them. Short meetings, tell them what you want, define it, and finish it off. Come out of the meeting with an answer. I would prefer that to emailing a big draft document of 20 pages. And the antibiotic policy should be specific for procedures or syndromes, should be scientifically sound, and should be easily accessible. This day and age, most hospitals will have intranets. Suppose you're still printing and putting it, let the people print policies or the part of the policy which is relevant for their department. If the policy goes on to 20 pages and they print all the 20 pages, which may not be all relevant for them, they'll have to search for what is relevant for them. So that's one thing. Challenges in awareness, that's another issue many face, even I've faced it as well. Now, I can't go around teaching the whole hospital. Therefore, I make use of infection control nurses, clinical pharmacists, education not only about antibiotics, about taking cultures which are relevant to the clinical picture of the patient and the right way to take the culture. Avoiding unnecessary samples, because if you do that, you may grow organisms. You may initiate unnecessary therapy, increased cost of side effects leading to antibiotic resistance. Therefore, educating everyone about the resistant pattern, optimal prescribing, including the timing, de-escalation of antibiotics. That's a difficult thing to do because you'll have a patient in front of you who's improving on, say, meropenem, but they actually can do with piperacillin tazobactam. So de-escalation and educating them on that, IV to oral switch. Now, many of you would have will be teaching nursing students as well. They're a resource to be tapped into. So we use the nursing students to take the importance of antibiotic stewardship, very simple things. No over-the-counter prescription. Every cough and cold doesn't need antibiotics. We ask them to take it down to the schools. Another part of implementation is when it comes to doctors, documenting the indication for empiric therapy. Doctors have a lot to write. Sometimes they may forget to write the indication. So some ways by which you can overcome is by either having a small sticker or a rubber stamp where all they need to do is fill in the relevant part in the template. Separate area for indication in a drug chart, which I'll show in the next slide. If you're using electronic records, it'll be really good to have a mandatory indication column. Duration, again, to have a stop or review date on the drug chart. an automatic review date if you're electronically prescribing. So that's an example where you've got an indication there, and you can use a red color or something like that to put a line for stop or review so that the antibiotics don't go on forever. Okay, coming back to involving the clinicians, treating the patients, when it comes to ensuring appropriate therapy, not only for the policy, but for every individual patient who you're going to advise on, the clinician is very important because at the end of the day, they are treating the patient. So we use antibiotic recommendation forms, which look something like that. We have decentralized our infection control and antibiotic stewardship to nursing staff and antimicrobial pharmacists. I intervene only in certain areas where antibiotic advice has to be given. So the nursing staff have filled out that part, if you can see that, and that's my recommendation. They will take it back to the clinicians and feed back to me what the clinicians have done or said. Antibiotic stewardship meeting is more of a focused group in certain areas. That's in an ICU. We discussed all the patients on antibiotics, come up with a plan. And this one is quite tedious and time-consuming because everyone have to write it down. The sheet may go somewhere. Therefore, we become a bit smart. We've got everything on a computer. So from their mobile phones, the doctors can actually fill in this Excel sheet. The decision made comes onto their mobile phones as well in a nice, colorful PDF format. So this is done just by a little bit of tweaking within our hospital itself. One of our pediatric intensivists did this entire thing himself. We have an app where all these eventually come into an app, which is secure with the hospital. And if I'm out of town or out of country and they need advice, we use the app. Yeah. Restricting high-end antimicrobials is very crucial. So you would have your own list of antimicrobials. If a patient is unwell and you need an antibiotic for an emergency, it is always wise to keep some in stock so that at least the first dose can be given because the golden hour should not be missed. You still have 6 to 8 hours to decide whether it needs to be continued or not. And if I refuse continuation of any particular antibiotic, I just don't send the form across. I would go to the clinician or to the area or call them and tell them the reason why. For all you know, I may be wrong. The patient may be unwell and the antibiotic may be required. Audits, well-defined standards should be there. Immediate feedback. So our clinical pharmacists do the audit. If they find something wrong, they tell the doctor immediately. We collate all the data and present it on a weekly basis in certain areas, on a monthly basis for the entire hospital. So that's just some templates for surgical prophylaxis. We look into the total number of patients, those who had prophylaxis more than 2 days, where the prophylaxis is being given more than an hour before the skin incision, or it's given less than 30 minutes, the skin was incised too early, and showing a trend. How have we done over the last few months? Feedback. Audit meetings, not everyone will come for it. So we take the meetings and the audit to their meetings. So we take about 10 to 15 minutes of their time, either at the beginning or the end of a meeting, and present it in their space. This is something we have done just to show the antibiotic consumption and the number of patients on antibiotics. So you got the total number of patients in the unit, out of which how many are on antibiotics, how many are on meropenem, how many are on colistin or polymyxin, what are the percentage of patients, so antibiotics to patients ratio, how many of them are on antibiotics. So each area has this just as a tracker. They'll know how they're doing in terms of giving antibiotics and not giving antibiotics. Of course, it varies highly depending on the criticality of the patients and the units. So in summary, we're taking antibiotic stewardship to the patient area. Again, it's a team led by nursing staff, or led by me, but implemented by nursing staff. I'd just like to show, there's a person here in blue. She's not a nurse, she's not a doctor. She's a microbiology technician. So I gave an option for all the microbiology technicians to come in and see the clinical work. She came, and now she advises doctors on what antibiotics to use, what not to use. And I could say that people are listening to her as well. So that's the end of my talk. Thank you very much for your time.
Thank you, Dr. Vijay.